Good afternoon, everyone. We're going to go ahead and get started. Thank you so much for coming to this session. We've got a lot of great speakers that we're really excited about. Myself and my co-moderator, Kevin, we don't have anything to disclose. And we're excited for our session today, Sugar, Spice, and Everything Nice, Recipes for Sweet Success in both Pediatrics and Pregnancy Management. So our goals for today's session are first to help create a plan for how can we assess and address the side effects related to highly effective modulator therapy that we're seeing in children using a multidisciplinary approach. We also want to talk about the current state of practice for postnatal care for infants born to mothers who use modulators during pregnancy. Also want to try to provide some strategies to overcome access barriers when we try to use highly effective modulator therapy in pregnant women who do not have CF. And then lastly, we'll evaluate some of the concerns for women with cystic fibrosis who are considering starting a family while taking highly effective modulator therapy. So as many of us know, modulators have become much more prevalent in recent years. So if you look at the diagram here, we have the years on the x-axis, and then we have the percent of the CF population who has not had a lung transplant on the y-axis. In the dark blue, you see patients who are ineligible based on either their age or their genotype for a CFTR modulator. And as we move from 2018 to 2023, you see that the percentage drops dramatically with only about 8% of patients in 2023 who are not eligible for modulators. As you might expect, a good portion of our patients, over 75%, are on Trikafta or ETI, and then we have about 4% on ivacaftor, and then very few patients on the other modulator therapies. And then something a lot of us are also aware of is that we've had a CF baby boom. And so since the availability of CFTR modulators, we've seen a dramatic increase in the amount of pregnancies in people with CF, whether those be planned or unplanned. And so we really need to think thoughtfully about our patients with CF who may be considering having a family and what considerations might they keep in mind in regards to if they want to continue their modulator, and what does that look like for baby after they're born. So for today's session, we have 4 great presentations. First, we'll talk to you a little bit about how we can assess side effects in children taking ETI, and we have a great team from Boston Children's. We have Sarah Kubiak, who's our pharmacist, and Lena Joseph, who is the pediatric program coordinator. Next, we'll discuss pregnancy and infant care with ETI, and we have Sabrina Sherwood, a pharmacist from St. Luke's. Next, we'll talk about using modulators in moms without CF, and we have Wendy Bullington, a pharmacist from the Medical University of South Carolina. And then lastly, we'll talk about a real patient who took a modulator during her pregnancy, and we'll have Lauren Miller, who interviewed Elise, a mom with CF.
Well, good afternoon, everyone, and thank you so much for attending the Pharmacy Symposium. My name is Kevin Lundebaugh, and I've had the privilege of co-chairing this symposium with Taylor. We are delighted to share these speakers with you. I am the pharmacist in both the pediatric and adult cystic fibrosis centers at the University of Virginia in Charlottesville, Virginia. And I wanted to take just a few moments to orient everyone to the first presentation, because we're going to be talking about one of the projects that's been a key focal point for the Cystic Fibrosis Learning Network. So for those that don't know, the CFLN, or Cystic Fibrosis Learning Network, is a coordinated network of 42 CF programs, 18 adult and 24 pediatric, that looks at improving the care model by taking into account the everyday interactions between people with CF, their families, our physicians, and our interdisciplinary teams. Teams consist of a triad with a physician leader, a quality improvement lead, and a patient-family partner. And we learn from each of those interactions and work to improve care through a quality improvement model. Currently, there are 4 key aims of the CFLN that they are looking at, and these include mental health, modulators, which is what we're going to be hearing a little bit more about today, models of care, as well as equity, racial justice, diversity, and inclusion. So just to orient you a little bit more to the specific modulator project that we're going to be discussing, this was part of an innovation lab or an iLab. And this specific iLab was looking at screening for side effects in people with cystic fibrosis taking ETI therapy. So in order to create an iLab, we start with a design panel. We had 10 experts from across the country in various roles talk about what our deliverables should be. This included our aims, our family of measures, as well as creating a key driver diagram and determining whether or not programs were interested. The 42 programs were then invited to participate in the iLab, and from there we had 21 programs opt in, 8 adult programs and 13 pediatric. And what they were aimed to do is to improve their screening processes for side effects related to ETI. From there, we then will create, revise, and refine a care change package that can be used by first all teams within the CFLN, but then also hopefully spread outside of our network to greater care centers at large. And the overall results of this project showed that we were able to increase the screening rate from about 67% at baseline to 80%. And side effects were identified in at least about 1 in 5 patients or people with CF that completed side effect screening for ETI, with the most common side effects being reported as mood change, brain fog, and weight gain. For more information about the iLab as a whole, you can visit poster 752 tomorrow. But without further ado, I'm going to introduce our first 2 speakers who will tell a little bit more about their experience with side effect screening in the pediatric population.
Great. Thank you so much, Kevin and Taylor. Lena and I have no disclosures today, and we will be discussing our center's experience with ETI and pediatrics, assessing side effects, dose modifications, and mental health. So as Kevin mentioned, our CF Center at Boston Children's had the opportunity to participate in the CFLN Modulator iLab this past spring. Today we're going to be sharing the results of our Pediatric Center's ETI side effect screening project. We're also going to be discussing some dose adjustment strategies that we've used at our institution to help mitigate some of these side effects. And we're also going to be discussing some of the barriers that we face during side effect screening and management. It's hard to believe that ETI has been in our lives for only 5 years. For those of us who have been helping to care for people with CF since before its approval, the pre-ETI era truly feels like a lifetime ago. In this short amount of time, ETI has changed the lives of so many people with CF, and for patients with eligible genotypes, has actually changed the trajectory of the disease. Data has proven ETI to be the most effective modulator available, and with the approval for the 2 to 5 year age group just this past year, it is now considered the standard of care for approximately 94% of the CF population. Clinical trials have shown ETI to be a relatively well-tolerated medication, with the most common side effects being headache, upper respiratory symptoms, GI symptoms, rash, and increased LFTs. The side effects included in the US package insert are listed here. Please note that a side effect incidence of 5% or greater was deemed significant enough to include in this chart, and a 2 to 5% incidence warranted mention in the blurb below. As with any new medication, it's important that we pay attention to side effects that are reported post-marketing. Since the approval of ETI in 2019, there have been a number of published case reports of adults experiencing cognitive effects, mood changes, and sleep changes that are attributed to ETI therapy. Excessive weight gain post-ETI initiation has also been reported. The cognitive effects reported include symptoms such as brain fog and attention difficulties. Mood changes include symptoms such as anxiety, depression, and aggression. Sleep changes reported include symptoms such as insomnia, nightmares, and general fatigue. There has not been sufficient evidence to determine an overall incidence of these reported side effects, nor has a causal relationship been determined. Nonetheless, each reported side effect that a patient or family attributes to ETI deserves to be assessed, addressed, and reported as we continue to learn more about this medication. In practice, many families are reporting similar side effects in our pediatric population. In our experience at BCH, hyperactivity and trouble sleeping are often reported for our young patients. Similar to other ETI side effects, these symptoms typically occur with therapy initiation and self-resolve within a couple weeks, although some patients do require dose adjustments for ongoing issues. Unfortunately, mood changes attributed to ETI have been reported with our pediatric population as well. Concerns regarding the potential mental health side effects of ETI have been voiced by the CF community, and many families have come to clinic with questions about this potential association. In 2023, the European Medicines Agency requested that information regarding ETI's potential link to depression be added to the product label. When announcing this change, the EMA reported that updates requested reflect the psychological impacts reported by some people, and there is at least a reasonable possibility of a causal relationship of ETI and depression. The information highlights that reports of depressive symptoms usually occur within 3 months of therapy initiation, are more likely to happen in patients with a history of psychiatric disorders, and in some cases improved with dose reduction or dose continuation. At BCH, discussions about ETI side effects have historically happened frequently during clinic visits, although not with a standardized screening process or frequency. Documentation of side effects has also varied amongst providers. When I joined the CF clinic team this past year, I began modulator side effect screening as a part of my annual medication review and began documenting the patient results in my pharmacist note. When presented with the opportunity to participate in the CFLN modulator lab this past spring, our team knew this would be a great opportunity for us to not only improve our screening process, but would also give us the opportunity to track reported side effects and dosing schedules so that we could identify trends within our institution. Again, the purpose of this lab was to increase the percent of patients screened for ETI side effects during routine clinic visits. We could not determine causality from this screening, but we did ensure that all effects reported were assessed and addressed while this data was collected. On a weekly basis, we reported the number of patients seen in clinic who are eligible to screen versus the number of patients that we're able to complete screening for, as well as the number of patients who report currently experiencing a side effect that they attribute to ETI. Our center also opted in for collection of additional data, which included the type of side effect and whether or not the patient was on modified dosing as a result. So from March 17th through August 2nd of this year, 131 patients on ETI seen in clinic were eligible for side effect screening. And of these eligible patients, 115 patients were able to be screened. The blanks represent weeks in which we had no eligible patients for screening. I'm really proud of the fact that we were able to screen 100% of patients for most weeks, and almost all of the weeks were above the 80% goal. The weeks really varied in terms of percentage of patients who reported side effects, ranging from 0% to 72%. Overall, 30 out of 115 patients reported experiencing one or more side effect that they attribute to ETI. So to break it all down, we completed ETI screening for 87.8% of our eligible pediatric patients seen in clinic during this time. 26.1% of those patients reported currently experiencing one or more side effect that they attribute to ETI therapy. 6% of patients screened were on a reduced dose due to a side effect, and 3% of patients screened were on flipped AM and PM dosing due to the side effect. 39 side effects were reported, with mood changes being the most common at 8 reports. This category included symptoms such as anxiety, depression, and aggression that the patient or family felt was attributable to ETI initiation. This category of side effects was double the incidence of any other side effect reported. Looking at this in terms of percentages, 7% of patients screened on ETI reported ongoing issues with mood changes that they attribute to ETI therapy. Of course, we have no control group to compare these results to, but remember that for the inclusion in the package insert, a 5% side effect incidence was considered significant enough to include in the table, and a 2% incidence was considered significant enough to include in the table footnote. Also worth mentioning are sleep disturbances, excessive weight gain, and cognitive changes such as brain fog, which were each reported at an incidence of 3%. So the most important part of a project like this is, what are we going to do with what we've learned? How will this change our practice going forward? The first practice change that we've implemented as a result of this project is establishing a set frequency of side effect screening based on the patient's risk and history of side effects. Of course, side effects will continue to be discussed on an as-needed basis and at each visit, but this will be the cadence of formal side effect screening. As side effects most commonly occur with initiation, we plan to continue assessing side effects 1 to 4 weeks after initiation, and then at least every 3 months during the first year of therapy. If the patient experiences no side effects during that time, we will continue to check annually after that point. Another practice change that we've implemented is in regards to screening documentation. We've learned through this project that having a centralized modulator tracker for side effect screening helps us to quickly identify who is due for screening as well as identify side effect trends. So we plan to continue this practice. I will continue to document screening results in my EMR pharmacist note, but can do this now in a much more streamlined and uniform way as one of our providers created a dot phrase for screeners to use. So what do we do when a side effect is reported? Even if it's not entirely clear if the symptom is due to ETI or not, there are ways that we can adjust dosing to potentially mitigate the side effect and also provide some clarity for our patients on potential medication association. We don't have good literature to guide us on dosing in various side effect scenarios, but these are some adjustments that have anecdotally worked for us at our center. With side effects that commonly occur with initiation, such as GI upset, hyperactivity, trouble sleeping, or rash, we usually consider waiting it out, as many of these symptoms or side effects tend to resolve with continued therapy. If the initiation side effect is severe, we would instead hold therapy and consider restarting slowly with an up retitration schedule. For this type of scenario, we would typically touch base with the patient and assess for resolution every 1 to 2 weeks. Flipping the AM and PM dosing. We don't really know how this works, but it likely involves the patient sleeping through the peak effect of the medications. It does seem to resolve side effects such as trouble sleeping, hyperactivity, headache, brain fog, and drowsiness for quite a few patients. We usually consider this option if a side effect doesn't resolve within 4 weeks. If flipped dosing doesn't help, we can consider decreasing the dose and monitoring for symptom resolution. For severe side effects that are significantly affecting the patient's quality of life, a drug holiday should be considered. This is also helpful if the patient isn't sure if ETI is causing the symptom. Some time off of the medication can help provide clarity around this. For this scenario, we would typically assess for symptom resolution about 2 to 4 weeks after therapy discontinuation. If the symptom hasn't resolved or improved, we can restart ETI with a slow up retitration schedule and increase to a tolerable dose. Another option to consider based on genetics is potentially switching to another modulator, especially if we know they have tolerated it in the past. So if we do decide to trial decreased dosing, how can we ensure that the dose is sufficient for the patient in terms of efficacy? For some patients, the decision may be to just simply monitor for signs and symptoms of efficacy. A sweat test can also be considered as a marker of CFTR function. We also now have the option for ETI therapeutic drug monitoring, which is super exciting. I think the question a lot of us have around ETI TDM is how do we interpret these levels and apply them to dose adjustment considerations in practice? So with that, I will pass the podium to Lena, our pediatric programs coordinator, and she will be discussing how we navigate some of the side effect management barriers.
Thanks, Sarah. So as a pediatric center, we have the whole range of ages, and as anybody in a pediatric center knows, we are constantly navigating this path with parents from the day they're diagnosed. What is a result of cystic fibrosis and what is typical development? When it came to assessing the side effects of ETI, it's particularly challenging in 2 age groups, toddlers and adolescents. Typically, toddlers experienced sleep disorders or tantrums. These were things that were reported by families, as well as hyperactivity, outbursts, changes in their behavior. However, according to the American Academy of Pediatrics, as well as Columbia University, multiple sources of behavior and analysis for pediatrics have reported over time that toddlers are searching out their independence naturally, and this is part of the growth process. So they become more independent physically by walking, climbing, exploring. They also develop language skills which enable them to express themselves, and caregivers must respond in kind. With a developing sense of self, they modify their behavior by imitating others and exerting their independence, as well as also experiencing separation anxiety. These changes can lead to behavior changes as they become frustrated, developing their own skills, as well as navigating our responses to these new skills. Those behavior changes naturally include tantrums, defiance, picky eating, and sleep disturbances. Anybody with a little toddler knows the pushback at bedtime for sure. So in our center, we needed to navigate that. The same is true with our adolescents. So adolescents are also exploring their independence while their bodies are going through these extreme changes. They can have side effects reported that include dermatological effects such as acne or rashes. The females report some menstrual cycle irregularity, headaches, which also could be attributed to hormone changes, weight gain, which is part of development as well, attention difficulties, and as well as anxiety and depression. None of this is done in a vacuum. We work as a multidisciplinary team to assess these changes that are reported by families and the teens. So adolescence as a time of great growth and development also includes some social exploration, such as trying to fit in with their groups, as well as trying to identify their self. They may try different clothing styles. They may have a shifting interest in activities. They may increase their risky behavior. They might feel invincible, as we all know about those who stop therapies. They experience mood swings, they test their boundaries, and they may even be resisting coming to clinic when the relationships were good previously. So in our center, this was part of what we had to navigate. We have a deep connection with our families, and we use the Partnership Enhancement Program skills and techniques. If you've not participated in this, it's a great way to modify communication skills within your center. Some of those things include creating trust and open dialogue with our families. It's called a soft opening in clinic, so not jumping into how are you feeling, even though we know on our agenda we have all of these medical needs. We want to know the whole person. This gave us an opportunity to hear from families about any changes in behavior as well as their concerns. In addition to the open dialogue, we like to have a discussion and set goals together with our families. So this also wrapped over into whether or not we wanted to start this medication. Just because you qualify doesn't mean that it's the right choice for you, your family, or your provider. So we would openly discuss the different side effects that the package insert includes and what we know from the research experience. We would encourage families to observe and note any changes once starting, as well as ask questions throughout. We had a robust communication experience with our families inside and outside of clinic. In addition to using the PEP, Partnership Enhancement Program, communication skills to establish trust, have open dialogue, and set those goals, we also really encourage them to talk about any emotions or to also be able to respond in kind to any concerns they brought up. Again, just trying to trust each other. So as I said, before starting therapy, we tried to do a pre-assessment. So for this, we utilized the Preschool Pediatric Symptom Checklist, the PPSC. It's currently designed for 2 to 5. However, I did a quick walk through the poster sessions, and you'll see that there are multiple centers doing exactly what we did and administering the PPSC. Some centers are starting it at 18 months. It's objective. Is this? Sarah, is this slide in there too? Oh, this is it. Wanted to give you a visual too. So it's objective. Parents go ahead and give us their feedback. It was typically our pediatric social worker who would give this to our families before starting, so we would obtain a baseline. And again, it was always a conversation. something they were concerned about if there was going to be any changes. So prior, here's what we're looking at. Mostly if there are any sleep issues, any reports of kids having belly or headaches, and then any other concerns about their behaviors. So the PPSC has a cutoff of 9. If it's 9 and above, the score would be considered warranting follow-up, and we would follow through on that. So after we would start therapy, let me go back. So part of our decision-making for whether or not to start therapy, we have a pre-clinic multidisciplinary team meeting once a week where we look at who's coming to clinics in 2 weeks. This is a great opportunity for anyone on the team to provide any feedback about any conversations that I've had with families, any underlying social and emotional concerns or needs. As we all know, children have baseline other conditions, how they're already coping with their enzymes, for example. Will they also be able to take the ETI in its granular form or pill form, depending on if they're doing a pill swallowing program? We addressed all of these issues at that pre-clinic meeting. So it was definitely a multidisciplinary approach to, is this the right therapy decision for the family? After we would start therapy, we used the screening process again. So for older kids, we also pre-screen, as most people do, with the GAD-7 as well as the PHQ-9. So after we would start, as Sarah had mentioned, we would screen afterwards for any side effects. We encouraged them to call us as soon as they noticed something so we could counsel and talk them through it. We would assess how they're giving the medication. Always a good time to re-educate on that, if there's any adherence issues, and answer any questions. If the side effect was reported, depending on what it was also a multidisciplinary approach. There's a lot of communication going on behind the scenes with our team to be able to make the right decisions for the family. Then we would provide the family with what options we as a care team had come up with and make those next decisions. So as Sarah mentioned, these are some of the things that we had considered, such as flipping the dose, reducing the doses, giving a holiday, and then considering if they want to go back to one of the other modulators. So here's our multidisciplinary team and some of the roles that we held. Sarah described some of hers. I also took the role of providing information on the medication as well as counseling on the side effects and really supporting the care coordination amongst the multidisciplinary team. Our social workers provide those baseline and intermittent mental health screenings and also navigate resources to move on. Sometimes we've had children get referred to our in-house psychologists or psychologists in the community if concerns arose. We have dietitians who also would help us with any side effects. We're taking a new approach, as most centers are, to looking at what nutrition means in a day of highly effective modulator therapy and really focusing on total health, not so much a BMI focus. And then, as we mentioned, the physician was also instrumental in those patient-centered treatment plans. So in conclusion, we found that establishing a really standardized ETI side effect screening protocol is important for all of us to follow. We had a questionnaire that we would provide in written form. We would verbally review it with families as well as patients. We partnered with them extensively to address any side effect concerns and make that plan, but we do acknowledge that further research is needed. How do we really determine the association or the incidence of those behavioral cognitive side effects, and how does that affect what's going on? How do we investigate the association of the drug levels? I know that there's some talk of getting a Trikafta level off of patients. Establishing what that optimal dose adjustment would be, and then what guidance to give as far as mental health screening. So we currently do this on an annual basis for people 12 and over, and then we're using the PPSC for those who are 2 to 5, but there's nothing for that age gap. We want to thank everybody and all of our support from the CFLN for sure. And then a special thank you to our senior quality improvement consultant, Rachel Gordon, for helping our slides look absolutely stunning.
In the interest of time, we're going to save all of the questions for the end, so you can be entering your questions into the Q&A chat, or at the end, we can invite you up to the microphone for questions.
Okay. Hi, everyone. I'm Sabrina. I am a clinical pharmacist from the St. Luke's Cystic Fibrosis Center of Idaho. I have 2 dogs and 1 cat, but I generally just talk about my dogs. So anyway, shout out Rosie. I have no disclosures. So today, I'm really excited to talk about something that I'm really passionate about. I'm actually trained on the adult side of things, but I came to a clinic where I'm doing both a pediatric and adult role, and I fell in love with kind of trying to understand how to take care of moms who are on highly effective modulator therapy, who then have an infant who either does or does not have CF, but is getting exposed to modulator therapy. And really came to realize that there might be a gap in communication with them and their pediatricians. So today we get to talk all about that. So first we're gonna get just a little bit nerdy, talk about some pharmacokinetic considerations of the modulators during pregnancy and lactation. Next, we'll talk about CFTR modulator safety in pregnancy and lactation. Then we'll talk about the current state of practice for postnatal care for the infants that are born to these mothers who are using highly effective modulator therapy, which I'll refer to as HEMT from now on. And then lastly, really importantly, I want you all to be able to take away at least one key note that you can write down and take to your clinic that will help you to kind of figure out a way to assess and address side effects that might be related to highly effective modulator therapy and how we can help prevent that gap in care that I hope to show you today. All right, and I always do just a little bit of a roadmap so you can see what we're going to cover and when. First, we'll jump into the nerdy stuff. Then we'll kind of get to some fun stuff, and we'll talk about CF Farm that I'm really excited to share with you a little bit more about today, and hopefully convince you that you all want to be a part of. I have had the pleasure of working with the CF Farm group for a while now, and you'll learn more about that later, but if you have interest, please email me. And then we'll wrap it up, and I'll ask you all to take down some notes, so be paying attention. All right, and Taylor already went over a very similar slide to this, but we have a problem on our hands, right? And it's kind of a good problem. We're seeing so many more pregnancies, and that is really exciting for our moms who have CF. But what I think we're missing is that we're not quite ready for that, and it's not our fault, right? But we are kind of catching up to how do we best care for these moms. And so I'd like to introduce you to what I call the mother and child-centered care team. The mom and baby should be at the middle of this care team with their team at the CF Center surrounding them. But also we have to remember that there are a lot of other people who need to be involved in the care of mom and baby. So first of all, MFM, OBGYN for the baby, primary care provider for the baby and the mom, and then a pediatrician for the baby. And really what I would like to emphasize today is that today's talk is not just for pharmacists. So I know a lot of you in this room are pharmacists and pharmacy technicians, but this is applicable to everyone. I think all of us play a role in making sure that this care team model lives on and that mom and baby can truly be at the center, because what I see in my day-to-day is that there's always this kind of break, either between the CF team and the OBGYN or the pediatrician or the PCP. For instance, I've had patients who will tell me, well, gosh, I am so confused because my CF team is saying I should continue this medication, but my OBGYN is saying discontinue this medication, and my PCP doesn't even know what that medication is. So, really what it's coming to is we all have strengths and we all need to work together to make sure mom and baby are at the middle. All right, so let's get a little nerdy. And this is like not even that nerdy for like what I usually present. So anyway, hopefully you won't fall asleep. Mayflowers is super exciting. I think you're going to hear more about that tomorrow. So I don't actually have a lot of data to share with you on that, but I will say that I think that will provide us a lot of insight into answers that you might have questions about today. There are 230 participants across 38 states that will be involved in this, and really it's going to look at the impact of pregnancy on maternal and infant health. They're also getting pharmacokinetic monitoring done to look at modulator serum levels in pregnancy and lactation to answer some of those questions that do remain. So, why is this a problem? Is this even getting to the baby? Well, yes, and so we have to kind of go back in time to show you the evidence for this. It all started with animal reproductive models, and they looked at the components of the medications that we have come to know today, but they didn't look at these medications in combination when you go to the package inserts. So what we do know is that each of these components do transfer to the placenta. But then when we talk about the impacts, so was there any impact on fetal survival? No. Was there any impact on organ development? Potentially with tezacaftor with some congenital eye issues. I would like to add the caveat that all of these findings were with maternally toxic doses. And then also some decreased weight that were found in the infants or the animal models that were exposed to these medications. So again, all maternally toxic doses. Next, breastfeeding. So, is the medication getting into breast milk? And I don't know, have you guys been to any other reproductive healthcare discussions today? Raise your hand if you have. Okay, I see quite a few, great. So you guys are all gonna learn a lot more about this, and this is really like a high level overview, but what we do know is that, yes, these components do get into the breast milk. I think the question still remains, what is the therapeutic level and impact? And I hope to show you a little bit today as to, I think it's a different answer for each individual person, and there are a few reasons why. But what we do know is that we should be looking at eye health in the way of cataracts, because we know that each of these, well, the ivacaftor component can lead to non-congenital neonatal cataracts in the reproductive models, even at non-maternally toxic doses. So we should be a little concerned about that. Next, this is why I really want to emphasize the fact that I think every single person is going to be different when we talk about exposure to a highly effective modulator therapy. So this is a really interesting concept about CYP3A4 development in infancy. So interestingly, infants are born without the proper cytochrome P450-3A4 system. And why that matters is because it's the primary pathway for metabolism of ivacaftor-tezacaftor and elexacaftor. And this expression doesn't really fully develop until infants are about 1 to 2 years of age. And this can really vary for each and every single infant. So what does that mean? Well, if we know that the 3A4 system is not fully functional, this could lead to increased levels of the modulator in the blood. Could that increase the risk of side effects? Right? So that's something that we are really looking at now, is to say, okay, well, gosh, we think there might be issues with liver and with eye stuff, but is it even more so in these infants that maybe can't metabolize them the way that we can as adults? So, leading to my next point, we all know that what we're looking for when we start an adult or a younger patient on a modulator on label use, we're looking at liver function and cataracts. So to kind of dive into this and see, well, how are we monitoring these infants that are exposed to highly effective modulator therapy? We decided to do a national survey. So a lot of you guys who are on the listserv probably saw this go out last December. And this is an effort of CF Farm, which I'll get to on the next slide. But really wanted to give a shout out to all of the authors that you see below. It took a lot of time and effort to put together this incredible survey that I get to share with you today. And I'd also like to put a plug in for the poster session tomorrow. We are poster 498 if you want to come and learn more, since I don't have time to go into all of the details. All right, so CF Farm Collaborative, here's my shout out. I hope I'm not the only one that gets to brag about them today, but first of all, I'm gonna say we actually have a new logo, way cooler. I just didn't get a chance to update that on this slide, so anyway, just know that. It's amazing, so if you just do it for the logo, I get it. But no, really, CF Farm is this really cool group of pharmacists and researchers, pharmacy technicians, everyone who wants to advance really the science of pharmacy among the CF population. And I am part of what's called like the CF Farm subgroup. It's called the Reproductive Health Group. You probably also saw a few emails from me or Kevin, just trying to gain some interest for that recently. And if you do have interest in joining it after everything you see today, because you're like, wow, Sabrina's so cool, my email will be on the last slide, I think. If not, just come find me and I'll add you. But yeah, so what we found from that subgroup is that there was this huge need, right, to see what are people doing out there to monitor these moms who start a modulator and have infants, and we're kind of worried about like what's going on with monitoring. So that's what started this all. Interestingly, we also have a lot of support from CFF to do this kind of research, as well as a sharing group. So they're all really backing this idea of getting more research out there to look at the effects of highly effective modulator therapy in this postnatal period and in utero. So the results, so we were able to collect a total of 100 responses. The majority did actually come from physicians and APPs. The next were pharmacists, nurses, and then kind of everyone else. And to be honest, that was really the intent of this survey. We wanted to get ideas from each person that we could, because we know that just because you treat a patient one way doesn't mean that your RD or your physician that you work with treats them the same, right? So we really wanted to get each individual's response to these questions to see what actually is going on out there in the US. So not surprisingly, the first statistics that we were able to conclude was this one. So 77% of participants recommended continuing highly effective modulator therapy in pregnancy and in lactation. I'll take this moment to also say that every single question that we asked, at least one person in the comments said, this is done with shared decision making. So I don't know if any of you went to the lunch and learned that they just had about reproductive health, but Dr. Fortner talked about the pathways of life and the pathways of kind of being a mom in this era, and the decision that kind of goes into continuing a highly effective modulator therapy is what really came to me when I was thinking about that, because it just makes me think like, yeah, this is a shared decision, right? And each individual person is going to be different, but in the end, it sounds like clinicians are kind of pushing forward with that recommendation of continuing therapy if it makes sense for mom. All right, and then I'll just go ahead and ask you guys this question. Okay, so do you have a process for providing education to people with cystic fibrosis who are taking a modulator upon discovery of pregnancy and who continue it during lactation? So really my question is, how many of you have a defined educational process for educating people who are using modulators in this setting? Raise your hand. Okay, I see a few, and that matches. Very few people have a defined process for educating patients on this topic. Really what we saw was, well, I verbally say something, or, I'll write something down in the EMR. But what we notice is that there is not a lot out there for a defined educational process. Now, when we asked people about what monitoring they would recommend, they did recommend that infants that were exposed to modulator therapy in pregnancy or lactation did get monitoring for cataracts and liver. So that's, your AST, ALT, bilirubin. And when should they do that? Well, most said within the first 3 months of life. There are a lot of, I'm sure, follow-up questions you have to these, and we did break down a few of those questions that we thought you might have. So feel free to ask me questions later or at the poster session tomorrow. And then we did find an area of improvement here. So most participants did defer management of infant monitoring to non-CF providers, but only half report having communication with those outside providers. So basically what we're doing is saying, hey, that's not my problem, but I'm not gonna tell them it's not my problem. So really, what I think we need to do here is think about how can we improve that communication process so that we know that these babies who are supposed to be at that center of the care model are not getting dropped. Because at some point, mom will be your patient, right? But the baby is out there somewhere else. And if no one else is taking kind of that responsibility for it, I do think that everyone in this room is capable of helping with that communication. So takeaways. So really what we found are these significant gaps regarding the utilization, education, coordination of modulator use during pregnancy and postnatal care. We also found a lack of standardization for monitoring. We also found that it's imperative that these non-CF providers are educated about modulator therapies, and we see a huge gap in maybe that disconnect. And so that's something that I want you to take away. Now, I wouldn't tell you about all these problems I see and not give you some kind of solution. So what I would like to say is that some people have found success with creating a specific handout with contact information. And this could be something that really what you do is it's education for your patient to take to their pediatrician, right? So you're kind of giving some power back to the mom by saying, here are the risks with continuing highly effective modulator therapy now that you've had your baby and you're breastfeeding the baby. But here are some ways that you can monitor for that. And although we are not the one who can order those labs for you, and maybe some of you can, which is awesome, here is the tool that you can take to your pediatrician or PCP to do that. So if anyone is interested in what I've created, feel free to email me or reach out to me. But really just kind of having some kind of layout and letter, I think, is one good step that you can do, especially if you're like me and your systems around are in really tiny cities and you don't have EMR connection to everyone. Okay, so key takeaways, we've talked about a lot today. What I want you to do now, though, is really just take a minute to write down at least one way that you think that you can improve the communication at your own center and take this back to your team after conference. Thank you.
Good afternoon, everyone, and thank you for being here today. My name is Wendy Bullington, and I am the pharmacist for both the Adult and the Pediatric Medical University of South Carolina CF Center. And today I'm going to be talking to you about a topic that is very near and dear to my heart. We've seen it with a couple patients in our center, and it's going to be using modulators in utero, assessing insurance barriers for moms without CF. I have no disclosures, but I do want to disclose that I will be speaking about off-label uses of medications throughout this entire presentation. Okay, a tale of two patients in utero. So I'm going to quickly go through two different patients we've had in our clinic and what the outcomes were. One mom without CF got modulator in time, and the other mom did not. And these are some of the outcomes. So for modulator in time, we had a female fetus with CF who was homozygous for F508del. At 23 weeks on ultrasound, they found a single loop of dilated bowel. At 28 weeks, the bowel lumen was 11 millimeters, suggestive of meconium ileus. And she was known to our center because she had an older sister that had CF, and mom and dad were both carriers. For our fetus that did not receive modulator in time, it was a male fetus with CF, and his genetics were 508del and N1303K. There were findings on the 18-week ultrasound, and at 31 weeks, mom presents to the adult CF clinic wanting to start ETI therapy. Mom's OB did not know much about modulators and potential options, and so mom was a nurse and had done some research and decided she wanted to come talk to us about possible options. For our modulator in time patient, insurance was TRICARE, and the prior authorization only asked if mom had one copy of 508 Del, which she did. So we were able to get it approved, and mom was able to start therapy at 32 weeks. By day 27 of therapy, the bowel dilation had resolved. For our child that did not get modulator in time, we got ETI approved within 4 weeks, but the day mom received her ETI, she had an emergency C-section for necrotic meconium ileus with perforation of the fetus. And so ETI was not started before delivery. For our modulator in time child, it was a vaginal birth at 36 weeks and 1 day. APGAR scores were great at 1 and 5 minutes, and the fetus passed meconium on the first day of life. Chest x-ray noted no bowel obstruction. This child was discharged home on day 2 of life, and she continued to get ETI through mom's breast milk. She continues on ETI to this day, and she's still pancreatic sufficient and doing great. It was a much rougher course for our infant that did not get modulator in time. He was intubated shortly after birth and had to almost immediately have a small bowel resection. He received TPN for the first several weeks of his life. Mom started her ETI as soon as she could after delivery, and they stored her breast milk. At 9 weeks, the patient had a CF exacerbation, and they put in a G-tube. Amazingly, at 10 and a half weeks, we were able to get ETI for our infant and start it. So what mom would do is she would give breast milk in a bottle with the ETI granules, and then whatever the baby didn't take, she would actually put through his G-tube so we knew he was getting the drug. At 12 weeks, he was transferred to the floor, and at 13 and a half weeks, he was discharged home on ETI. He's doing great now. He is a little plump 5-month-old who comes to clinic and makes us all very happy. So thinking of those 2 cases, my objectives for today are to summarize evidence supporting modulator therapy in utero, some of it which you've already heard, and then to discuss strategies to improve success rates for patients to get the ETI approval. So this is where the off-label parts start. When you think about modulator use in therapy, I feel like I have to say what the package insert says. It says there is incomplete and limited HEMT data from clinical trials on the use of ETI in pregnant females to inform drug-associated risk. However, as mentioned earlier in Sabrina's talk, there are increasing data out there about the safety of modulator use in pregnancy. Some of it from a survey from Taylor Kozar et al. In 2022 was published in the Journal of CF, and then the Mayflower study. So I did put some data there from the Mayflower study, but they have a poster that you can check out as well for more data. How about with breastfeeding? Again, the package insert said ETI is excreted in breast milk of lactating rats giving a dose of ETI. We also know that it's detectable and stable in the breast milk of human. There is a recent case report by Montez et al., and this infant was given ETI in utero. He did have CF. He was breastfed until 6 months, and he is still pancreatic sufficient as well. It's not without side effects, as previously mentioned. And so Jane et al. Published a case series of 3 infants with bilateral cataracts. So as we go to fight with insurance companies, it's important that they know that patient safety is our priority and that we have a monitoring plan for these infants going forward. And that's primarily what was mentioned earlier, lab work and making sure they get eye examinations. The biggest type of evidence I feel like I've used in the appeals that I've gotten approved, it kind of goes around the dangers of meconium ileus, right? We don't see these as much as we feel like we used to, and maybe that's because a lot of moms that have CF are on this and their children are born with CF. But we know that meconium ileus can impact CF, and it may be worsened lung function, it may be decreased fat mass after birth. And the main article that I use when I write my appeals is Tan et al.'s article out of Australia. And this is a retrospective case-controlled study of 162 matched pairs out of the Australian registry that looks at meconium ileus versus non-meconium ileus patients. If you look at the data that's presented from them, patients with meconium ileus had a decreased FEV1 of 7%, had lower BMI Z-scores, were more likely to use TPN, were more likely to have increased use of oral supplements. They were also more likely to have increased hospital days and increased risk of death. So we know that this is not, this is dangerous potentially for our children, so we may have an option for that. So how do we think about it, right? At least at our center and in the state of South Carolina, we encourage carrier testing for moms. If mom is a carrier, then we test the father of the child. And if that comes back where he's a potential carrier as well, the next thing we do is something called a unity screen. And this unity screens, it screens for fetal CF on a maternal blood sample using cell-free fetal DNA. And this is not 100% diagnostic, but it's near diagnostic. And then if that comes back positive, we consider chorionic villus sampling or an amniocentesis to know if our fetus has CF or not. And that's important, right? Because we want to start treatment, but we don't always know when. And what we are thinking is maybe sooner is better, right? So we know the vas deferens forms around 11 weeks, although it's unclear when it atrophies. And there's ferret data that shows with ETI therapy, it may be able to be reversed. We also know pancreatic function. The pancreas may begin to atrophy around 15 to 20 weeks. And I feel like we're starting to see this in case series now where we have infants that are still pancreatic sufficient several years after birth. And then as mentioned earlier, if we can prevent that dreaded meconium ileus, I think that that's a real benefit for our infants. So at this point, we have shared decision-making, as already mentioned, right? We have a discussion with the team, with the parents about the risks and the benefits and what we need to look for going forward. And if the family is on board and we decide that we want to work on approval, what is our pathway, right? And so obviously a prior authorization is going to be first. And I want to say, yay, we're going to get that PA approved, but the chances are we're not going to be that lucky and that PA is going to be denied, right? But some helpful tips, right? First one, read the question carefully that they're asking you. And that's how we got away with Trikafta for that first case, right? The PA only asked, it didn't ask if mom had CF. It only asked if the mom or the patient had one copy of F508del, which she did, and we got that PA approved. And so think about what they're asking and don't give them more information than what they're actually asking you for. I also like the question, have they failed other therapies, right? I will put in there, this is first-line therapy. Again, if the person on the other hand doesn't totally understand that we're talking about first-line therapy for the fetus and not the mom, they may see that and be more likely to approve it. And I think we have to just kind of be creative in how we're wording this. Most PAs are going to require a detailed physician note. And so we talk about putting the information in there that it's been discussed, the risks, the benefits, the shared decision-making, what could happen if it's not approved for the patient. And then a lot of times I don't do an urgent response for a PA because I feel like they're more likely to be denied. But if you know your fetus has a meconium ileus, as in the case for the second patient that we presented, urgent response may be needed because all I think about sometimes is what if we had made it more urgent and the mom had gotten that modulator in time. But we go to appeal, right? That's almost always the case. So the first thing we do is we have a very detailed letter that my genetic counselor wrote with me. It was really nice to have both perspectives in writing this letter. And I think it's important to utilize the most up-to-date literature, to utilize our listserv, right? There's a lot of great letters out there that are floating around. And this is where I get a little over dramatic, but I include the consequences of potential therapy denial, right? So this baby may be born, they may have an extended NICU stay, it's gonna cause patient harm, the emotional harm, whatever it may be. I really like sock it to them in that last paragraph, hoping the person on the other side will really feel that and be more likely to approve that. If that has failed, I'm lucky, I have our great pediatrician for our CF team here in the room. We go to a peer-to-peer, right? And that's where she's able to help answer questions with her counterpart that maybe I'm not able to answer as the pharmacist. And so I definitely want to say utilize the peer-to-peer if you have that option. Have the patient be involved in the process, right? If the patient's not on board, things are going to go much slower. So even though it took 4 weeks to get that ETI approved for the mom that didn't get it in time, she was calling frequently to her insurance. She also had like the patient advocate for the insurance on her side. And so they were helping us to get this approved. And then a delayed response may happen with an appeal, right? For those of y'all that know it, it can take 3 days to 30 to 40 days for this to be approved. And so I think this is an opportunity for us to continue to educate our community that's maybe not as involved in CF to know about this possible therapy so they can be referred earlier. So this is something interesting that's come up on the CF listserv in the last couple of months, right? And so how do we define the person with CF? You have a fetus inside the mom. The mom may not have CF, but the fetus does. So in South Carolina, we have a South Carolina Fetal Heartbeat and Protection from Abortion Act. And this, I wrote my notes down, it defines a human fetus and unborn child as an individual organism of the species Homo sapiens from fertilization to live birth. So by that definition, in my opinion, you have a person inside a person and that person has CF. So when I get asked some of these questions, which we're going to go through in just a minute, I'm going to say, yes, this person has CF. And I recognize that's different from state to state, but as you'll see in these next couple of slides, we have to be able to define this. And so this is where it goes, right? It's approved, what's next? So copay assistance, right? Like the worst thing ever is that we get this drug approved and then mom can't pay for it, right? We were lucky in our 2 patients that one had TRICARE and one had Medicaid, and this was not an issue for us with those 2 patients, but what if mom has insurance and her copay is $10,000 a month? So you have to read the qualifications closely. So you can see here with HealthWell, right? These are the ones that have CF copay assistance. You just have to be treated for cystic fibrosis. So mom, yay, treated for cystic fibrosis. Patient Advocate Foundation doesn't ask any questions about if the patient's being treated for cystic fibrosis. The Assistance Fund says the patient has to be diagnosed with the disease for which you are applying. So it gets a little bit more interesting. And then when you think about Vertex GPS, I like to say it's complicated. To enroll in GPS, the patient has to be prescribed a product, right? The healthcare provider must have completed the form. It's evaluated on a case-by-case basis with your rep. But this is the question. For those of y'all, and I don't know how many in this room have filled out this form, there is a new line added to the form. Does the patient have the disease for which the product is indicated? And if you answer no, you can't get any further. If you try to make the patient less than 2 years of age, because I tried that, like giving the date of birth of the infant, you can't get further than that. It automatically shuts the process down. And so at our center, I didn't know what to do, right? Because, and I don't know if you've seen some of this at Rush, or I think UNC, several of us had responded on the listserv. I met with our center director briefly, and I said, how would you respond? And he said, I would say yes. And I said, I would too. And he's like, in South Carolina, this is a person. So we emailed our lawyer for our institution, and I said, can I go to jail for this? If I lie, I'm not lying, but we recognize here we're skirting the truth with some of these. And she told me no. And so really, from what I understand, these questions are because the drug companies are not allowed by the FDA to promote off-label use. And so this is how they protect themselves from that. So going forward, I would just encourage you to maybe talk to your teams about this ahead of time and see what your providers feel comfortable with in answering some of these questions, because you are going to be getting hard stops about this in the future. And then kind of my last thing I wanted to talk about is when do we try to transition for our infant, right? So we realized for our 10-and-a-half-week-old, the breast milk wasn't cutting it. Was it because it just wasn't enough? Was it because it had been frozen and maybe not enough of it was really working? So we decided at like 8 weeks to start for approval for him. So I think we have to be aware in clinics about when do we need to start making that transition. Mom can't breastfeed any longer, infant isn't tolerating breastfeeding, whatever it may be, we need to already be kind of thinking about it out the door as care providers for our team. And then again, we need to have that data to be ready to appeal it, because I guarantee you we're going to have to appeal this one as well. And then, as we talked about Farm CF, I'm going to be hopefully working with Sabrina's group on a case series. So if any of you out there have an infant less than 2 years old that's received ETI therapy, I really want to work on a case series talking about safety data. So I feel like that will help us to be able to get these meds approved if we have a big enough group of patients, and then we also say, okay, here at least are the safety outcomes that we've seen from those patients. So please reach out to Sabrina or I if that's something that you're interested in. And then I want to give a special thanks to my genetic counselor. I wouldn't have understood a lot of these tests without her, and again, a lot of the information she provides is really helpful in writing the appeal letter. So if you are lucky enough to have a genetic counselor at your center, I think it would be really beneficial to include them in writing some of these appeal letters as well. And like that, I'd like to say thanks.
So nothing to disclose. And I just want to say that the video is this portion of the symposium for sure. Our hope was to do this live, but Elise was not available today. So Kevin and I did this in advance. Simply one person's journey, and Elise should definitely have top billing. That should be her name up there. So focus on the right side of your screen. Oh, I'll go backwards. Hello, everyone. Lauren here. I've been the nurse and coordinator with the Pediatrics CF team at UVA for 23 years now. I want to thank Kevin and Taylor for giving me the pleasure of chatting with Elise about her experience with pregnancy while on an ETI. And thank you, Elise, for sharing a part of your journey with us.
Absolutely.
And all the folks here at NACFC 2024 in Boston Live and tuning in from other corners. You want to tell us a little bit about you?
Sure. So my name is Elise. I am 36. I have CF. I was diagnosed when I was 2, I think. And I have a son. He was born last year in October, so he's coming up on a year. And he does not have CF. We can get into details of that as we start talking, but it's me. And I am so happy to share my experience. Overall, pregnancy was easier than I thought it would be.
Well, let's start with you telling us a little bit about your journey with modulator therapies.
Sure. So I have the most common CF mutation. So that meant that Orkambi was right for me. So when Orkambi came out, I started on that, and that was pretty cool. And that worked for me pretty easily for a while. And then Symdeko came out, its big brother, and I tried that. And unfortunately, my liver couldn't tolerate that. So we reverted back to Orkambi. And then when Trikafta came out, I was super excited about that. Was really, really ready to try it. But unfortunately, again, my liver couldn't tolerate that at the full dose, which was kind of crushing. But my doctor and I came up with a plan to modify the dose to see if I could tolerate that. So instead of taking like the 2 orange in the morning and the blue at night, I would take the 2 orange one day and then the blue the next day and so forth. So think of it like 50% dose. And that was great. My liver could handle that. And so for years, I coasted on the 50% Trikafta dose. And that's what I was taking when I was pregnant. And that was great. And so we did that. But then just recently, really just a few months ago, my doctor and I decided to see if we could ramp up to 75%. And that has also worked. Happy liver numbers. So that's what I'm doing right now.
Great. I'm sure there was some stress around not being able to take a full dose, and like how wonderful that you persevered with your doc and found a regimen that's safe for your body. How do you dose the 75%?
I have to like
share with that. I'm sure.
Sure. I have to like map it out. But basically what I do is like on day one, it would be orange in the morning, blue at night, and then nothing. So then the next morning there's nothing. And then I start that over again. So it's like orange, blue, nothing, orange, blue, nothing. And so I think that means that over the course of 3 days, I would take 2 full doses. I had to like map it out and look at it, but that ends up being like the 75%.
That's great. Are there plans to try increasing to the full dose at any point?
Yeah, potentially. It's like I could either do it now or wait. Like we do want to try to have a second baby. And so she definitely doesn't want me to do that while I'm pregnant. Don't want to mess with anything. Just kind of keep the status quo. So it would either be like now or after we had our second. So I don't know yet, but, yeah, I'd like to try. It seems like I just sort of needed to like get my system used to it and then bring it in slowly. And so I have faith that going up to 100 will work eventually, after I coast on the 75% for a while.
This is great insight and hopeful for those, other folks who might not tolerate full dosing to start. So would you say being on a modulator played into your decision about getting pregnant?
Yes and no. Like, I think I would have wanted to get pregnant even if there weren't modulators. But being on it for the time that I've been on it has helped me stay healthier, which then just gives me more confidence going into pregnancy that I can tackle that. I also have to believe that it helped me get pregnant. I listened to a webinar before we started our family planning that was about modulators and fertility. And that was pretty cool. It showed some data that more women with CF are getting pregnant now, being on Trikafta than before. So that was encouraging and was certainly the case for me. So I have to believe that helped.
Indeed. Yes, and the baby boom with ETI is a real thing for sure. A great one. Would you mind sharing a little bit more about the webinar and where you found it?
Oh gosh, I don't remember where I found it. It was years ago. I
put that in later.
I'm on a bunch of like email lists about CF research and stuff like that, and I volunteer to be on any like studies and stuff. And so I think I'm just like on a bunch of these lists, and every now and then they email with information that's helpful. And so if it applies to me, I try to listen when I can or join a discussion group, that kind of thing. So I'm sure I found it probably somewhere through the CF Foundation in some capacity. I don't remember it though, but it was helpful. That I definitely retained the information that the backup of the data that they were seeing and how that just like helped me feel a lot more comfortable going into pregnancy, knowing what they knew, because Trikafta was so new and like they hadn't really done any research of how it affected pregnant women, but it seemed like that it was easy.
Yeah, we are still learning. Still a new frontier, an exciting one. So did you or any of your care team have any concerns specifically about taking ATI while pregnant?
No, not at all. I mean, it's like keeping me healthy was my most important goal for a pregnancy, as well as my care teams. And so since being on Trikafta has made me healthier, it's kind of like a no-brainer. And like I said, that webinar also mentioned that there hadn't been any signs that modulator was unsafe, either for mom or baby during pregnancy. So that eliminated any concerns I had there. After giving birth, I had questions about breastfeeding and does Trikafta affect that in any way, but there didn't seem to be concern from my OB team, my CF team, or even my son's pediatrician. So I'm still breastfeeding. So
That's awesome. It's great to hear and helpful for others for sure. So we know that since ETI can impact newborn screening, that often is an area of concern. And it sounds like you were able to meet with a genetic counselor and that Henry's dad had full gene sequencing so that CF was not a concern for Henry. Is that right?
yeah, that's correct. Yeah, we did that through the hospital that I see. And, we of course knew my mutation, and we just did the full on screening for my husband. And he's not a carrier, so we didn't have to do anything further.
Right. So would that be something that you would recommend, I would assume, for other folks?
I think so. I mean, everybody can do what they feel is best for their family, but for me, I always like knowledge and information, and so to me, it wasn't going to change whether or not we wanted to have kids. Like, we already knew that. It just may have informed the route that we took to get there. If he had come back as a carrier, that could have explored many different other options. There's so many out there now, IVF, surrogacy, adoption, but we didn't have to explore those paths because of the knowledge we gained. But had that been different, that could have helped inform what we may do next. So I would recommend it. But, other people may feel differently, and that it doesn't matter to them whether or not their baby would have CF. What's good these days is that, heck, these babies and these kids with CF are so much healthier than I was when I was that age, that it's far less scary for the parents and it's so much more manageable. But I personally would not want to have had a child with CF if I knew I could do something about that. So, I think maybe IVF could have been our route if we had learned differently, but luckily we were in the clear.
Oh. So wondering if there were things that you wish you knew before getting pregnant.
Not really about modulators. I think I had that under control, or understood it at least. The one hiccup that I did have related to CF during pregnancy was that I started culturing Pseudomonas while I was pregnant and hadn't really before, so that was new. And normally my doctor and I treat a new infection like that, really aggressively to start. We get those strong IV antibiotics and really try to knock it out from the beginning, which has been successful in the past. But those medications could have been unsafe for the baby. So we couldn't use the strong ones. We tried some milder IV antibiotics, but they didn't really kick it. So now, I don't know, I might be stuck with it, but we're managing it with inhaled antibiotics every other month, which helps keep the burden down. And there's clinical trials out there that are that would fit for me. So there's certainly hope for other stuff, but that was a bummer. But there's nothing we could have done about that. You can't plan when you're going to get an infection, and I don't know that we would have done anything differently, but 9 months is a long time to not take a strong medication if you needed it. So that's just something to be aware of, but I don't think it would have changed what we would have done.
Sure. No, I'm sure that was unsettling. It sounds like you and your team did an awesome job just attacking it the best you could. And a good reminder, right, that no matter how healthy anyone enters into pregnancy, there always can be some surprises. That's good preparation for parenthood, right? No. Were there other ways in which your care team best supported you and your needs while you were pregnant? And
My team's great. I really love my team. And I mean, the CF team at my hospital is awesome. And I mean, Lauren, I know you're with peds, but the adult team is just.
So I can say they are too.
Yeah, they're great. So I've always felt supported by them, and they would check in with me throughout the pregnancy. And my OB team was great. I mean, I was seeing them frequently because they put me with the high risk OB team, and so they just check in on me more often and have more like ultrasounds and things like that. But I mean, other than that Pseudomonas flare up, like my CF was really controlled during pregnancy. My FEV1 stayed roughly the same. So that actually wasn't the thing that we focused on. But I do have CF diabetes. And so that was like the big thing to focus on. I mean, normally I talk to my endocrine team once every 3-4 months. But I mean, we were talking like every other week, if not every week towards the end. But they're great. And we did that as much through telemed as possible. So that was super easy on me. I wear a CGM. So it was really easy for them to just like watch my numbers from afar and be able to give me advice if they needed to make an adjustment to my insulin dose, which we definitely had to do often to keep my blood sugar within target. Because your blood sugar targets when you're pregnant are like a lot smaller than they let you get when if you have CFRD otherwise. So that was the thing that I think we had to focus on the most, but I felt super supported by all the different teams I was working with. The telemed option is great. I love it.
Yes, the silver linings, right, that remain of our COVID period. It's great that that's such a workable option for you. And it sounds like you were navigating a lot throughout your pregnancy.
Isn't that the baseline for all CF patients? Yeah, I think we just
and more.
we just, I don't know. It is sort of the standard, but you just do what you got to do.
Yeah. How was communication between your teams, would you say?
Oh, that's a great question. Good. I mean, because I was seeing everybody through the same hospital, all of my notes about me were all in my chart. And so, anybody could just log on in and look at it. I mean, I think that all happened behind the scenes. I didn't see a lot of that, but I never got the sense that they were not communicating. And even a couple times I could tell that they had like clearly read the notes. They definitely did. And then during birth, I know that they were all in cahoots in the background, making a plan, especially again with the blood sugar control. That was like the biggest thing we were talking about on birthday. And then my doctor came to see me in the hospital. That was just the best surprise. I guess got her shift and came to see us, and she was not even there to talk about CF. She just wanted to meet the baby and say hi to me, and that was this.
Lovely. Because what would you share with others on HEMT and thinking about getting pregnant? Any pearls, words of wisdom?
I mean, I guess that a healthy mom makes a healthy baby. Focus on yourself and being in the best shape that you can be. Before we got pregnant, my doctor used to tell me that what mattered more to her was what FEV1 I had going into pregnancy. Not really what happened during pregnancy. I guess the idea was that if you go into it healthy, you'll come out of it healthy, even if there's some bumps along the way. Like I remember her saying, like, if it dips down, like, don't worry, we're going to get you back. So she was not that worried about what happened in the middle. It was just, what can you do to make sure that your starting point is the best that you can make it be? So focus on you. It's easy to worry and focus about baby, but we CF patients are very important, and they're going to focus on you and make sure that a healthy mom is there as well.
Could not think of sounder advice. So thank you for that. And now what about Henry, right?
Henry, let me get He's napping right now. He's
Okay.
asleep. Otherwise, he could.
Well, maybe we can pause and
But
have a
he.
hello.
But
I said maybe we can have a pause and then have a hello.
we could, yeah. I mean, yeah, he's good. He's got a cold right now, which he then gave to me, of course. Which as yeah, that's something. I don't know. I guess I knew that it was coming. Just that, like, your baby's gonna get sick, and you.
Are we done? We're done. And there you go. That's what I have. Thank you, Elise.
So we are going to get to all the Q&A in just a second, but we actually have a very special announcement. Dave Young is going to come up and make that announcement.
Hi there. Sorry I'm delaying the Q&A. I'm Dave Young. I'm a pharmacist at the Adult Center at the University of Utah. And it's really fitting that this session, I'm going to take a few minutes to recognize somebody that's been a stalwart in the CF pharmacy community for years. Spent 40 years of his career taking care of infants, children, and adolescents with CF. Bob, can you come up here for just a sec so I can embarrass you? This is Bob Kuhn, Dr. Bob Kuhn from University of Kentucky. And it's very fitting that we're going to do this recognition. This is not CF sponsored, it's CF pharmacy sponsored. So sorry if you're not a CF pharmacist, but you can feel our love, hopefully. World Pharmacy Day was like yesterday. That's pretty cool, right? So it's fitting that there's a lot of history and that here in Boston, and we're here on a historic day of that day. And also another historic day happened for the CF pharmacy community. The guidelines for care team models got published, which now require pharmacists and pharmacy technicians to be part of the team. And when I first started and Bob first started, we weren't even in the document. We weren't there. So it was a historic day for our discipline, which is really cool. I wrote down, I woke up at 2 a.m. thinking about what am I going to say about Bob, because I could go on for a whole session, but I won't do that to you guys. But I did come up with an acronym that's it's Bob Cares, and it's and the BOB stands for BOB. That's Bob. The CARES does stand for something different. So CARE, the C in CARE stands for. If I had to describe Bob, there's 5 words that came to my mind. There's a lot more than that, but these 5 words stood out to me. One is C stands for compassion. If you spent any time at all with Bob, any microsecond of time, he lives by a motto that nothing comes before the care of a sick child, which was highlighted even in this session today. The A stands for advocacy. He spent his entire career advocating for pharmacists and pharmacy technicians to be multidisciplinary team members, and he was one of the first people to do that in the entire country and / world. So thank you, Bob, for that. His research, that's what the R stands for. His research is very expansive. It ranges anywhere from getting approval of Cipro in children to defining the role of a CF pharmacist and pharmacy technician on care teams. The E stands for excellence. Excellence is something that he demands of himself every day, and it's something that he demanded of his students, residents, fellows, and patients and families counted on it for him to bring his A game every day, and he did. That's awesome. And the S stands for service. This guy spent his entire life serving others, his neighbors, his friends, his family, his university, and the worldwide CF community. To me, the global CF community, and especially the CF pharmacist, pharmacy technician community, cannot repay you for all of your sleepless nights, hard work, and dedications towards improving our lives. What we can do is thank you, Bob, for all of the pharmacy students that you taught, for all the postdoctoral pharmacy residents and fellows that you mentored, for all the pharmacists and pharmacy technicians that you encouraged and supported, and for all the multidisciplinary team members that you touched and collaborated with, and for the patients, especially for the patients and families that you provided expertise, comfort, and love. Bob, we love you, wish you and Jan and your family their very best, and we'll give you this award that's really cool, actually. It is it's like a really cool lung thing. I found it on Etsy. It's really neat. Say something. Can't thank him enough for the past 40 years, and if you see him, give him a hug.
I have to make a confession. I was taking out to lunch and I fell asleep about a half an hour ago in this session, so please apologize for that, but I did wake up, okay? No, I want to tell this quick story. First of all, it's so gracious, David, and now I know why Lauren wanted to make sure I was in this session, okay, so I figured that out. But I want to tell you that the story that got me into CF, and if you come tomorrow, you'll hear more about it, but if you don't mind, it'll take a couple minutes. So I went to pharmacy school at Ohio State, and I had a previous undergraduate degree. Now, this is back in 1977. And I had to take some electives because of the BS, you take those. So I took this course on TPN and medical dietetics. Long story short, the professor there was going to this camp with CF children doing a pancreatic enzyme study. All right? So I went. I was the only pharmacy student who went. And I got to talk to the parents of CF patients. Now, think of how things are different today. We're talking 55, 61 years of age. That would probably be, the life expectancy was maybe 16 or 15. So I got to meet a lot of these parents, and they asked me what I was going to do. Are you going to medical school? No, I'm not going to medical school. Are you going to nursing school? No, I'm a pharmacy. And pharmacists, oh, I hate my pharmacist. Oh, now remember, ladies and gentlemen, that was back when you went to a pharmacy, you walked in the door and you had to pay cash for a prescription, the vast majority. So many of these patients from Ohio would go to Columbus or Toledo, go to the CF Center, get all this wonderful stuff done, come back with prescriptions to the local town, and these pharmacists were clueless. Chloramphenicol for a pediatric patient. So it was really a love-hate relationship. So I decided at that point, either I was going to succumb and go to medical school, or we were going to change what pharmacists did and how they got involved in CF care. So I went to the first meeting in Toronto, the first North American CF meeting in 1987. So just to show you, that's when I came at, if a pharmacist can't, just because they're not doing something in an area, it doesn't mean they can't. And the love that I've seen from patients and parents and CF teams throughout the years in the centers has just been fantastic. And thank you so much for this award.
Congratulations. We're so happy that we were able to surprise you today and honor you for all of your accomplishments. So congratulations. And I'd like to invite all of the speakers back to the stage. And we're going to go through some of the question and answers in the chat. But if you would like to be brave and come to the mic, we will also take your questions as well. So the first question I have is for the Boston Children's Group. Did you have a standardized tool that you use to screen for side effects? Is it validated?
That is a very great question. We could talk for a very long time about different ways to screen patients, and our screening methods have kind of evolved over time as part of the project. But we have always felt that screening should be a conversation with patients and not just a paper survey. So we did eventually put in a paper survey along with our verbal discussion, but nothing has been validated. It was all something we put together and we discussed with patients. I think the most important reason we wanted to discuss with patients as a conversation is if a side effect was brought up, we wanted to be able to discuss it and address it at that moment. We also very often encountered patients when we asked about side effects, they would reply with, no, nothing, that's not worth it. And so we would then prompt further, and if that was a paper survey, they probably would have just circled no. to see what they're experiencing, even if they feel that it's worth the benefit of the drug.
So our next question is for Wendy. So while there's more of a leg to stand on if a fetus has findings of meconium ileus, what about families asking to start ETI if there's no evidence of CF complications found in utero? And how do you argue for it with insurance?
So I have not had that happen yet, to be honest, but I think there is growing data that it may be beneficial if the child has CF to, as we talk about, prevent pancreatic insufficiency and potentially with fertility for males. So I think you could argue with that data. And with the data that if you started earlier, maybe if there was meconium ileus, we have prevented that from happening in utero. But I definitely think without meconium ileus, you have to make sure that you have that good detailed discussion with mom and dad, right? Because potentially the risk could be less. We don't know. I think we're going to find more and more cases of this, and we'll have more information over time. But in the end, I think that we have a bigger push as a medical team if there's meconium ileus, and I think if there's not, then we really have to make sure further shared decision-making is there. So we know they're not without side effects. Our first mom that we talked about, we ended up having to stop therapy and breastfeeding about 8 months in because she actually started having very abnormal LFTs, and it became unsafe for her to continue it. So I think we have to think about all of that. So I think it's each team and each parent's decision.
And then the next question for Sabrina. How do you educate parents who decline highly effective modulator therapy for their child because of potential adverse effects, particularly behavioral or mood? Oh, sorry. This is probably more for the Boston Children's team. I jumped ahead too much. That they have heard about on social media or from other CF families. We want to respect family wishes, but there's compelling data showing early initiation is better.
Do you think that's for us?
I think it could be for anyone, honestly. We're all great pharmacists.
I didn't hear the beginning of the question.
Sure. How do you educate parents who don't want to give their kids side effects because of behavioral or mental health?
Yeah, I think it's an open discussion that we have with patients and families before starting on therapy. We talk about all potential side effects, things that people report things and we don't know if they're associated or not. But I think it's a family decision. It's not something that we're forcing the patient to start by any means. It's just part of the conversation. We also talk about the fact that if they do want to try, we can always try and stop if they experience a side effect. But it's really just acknowledging the fact that there's a lot of information out there that can be overwhelming, and there are ways to work with patients and families if side effects are experienced.
I would just add that we keep it an ongoing discussion. So even if they come to clinic and are declining, we could open it up for discussion at a future visit and really take a look at what's the health status of the child, what's been the history. It's a full process to have that conversation.
And can I add something? I was going to say, if you haven't seen it, I'm pretty sure it's a Vertex product, but it is a little book that I have found helpful that shows lung decline. And so it shows, I think it starts at like 18 months, but it's a visual of lung decline. And so even if the child or the adolescent isn't having potential drops in FEV1 that are symptoms that are noticeable, it shows across the CF spectrum. And I found that visual, I have the same issue. I found the visual to be very helpful with patients and families just to see there may be damage that you're just not noticing.
Okay. So this next question is for Sabrina. So when you're talking about children born to moms that took ETI during pregnancy and you're making these recommendations for extra monitoring, specifically here, we're talking about ophthalmology exams. Are there any insurance limitations that you've observed in practice?
Yeah, it's a great question. To be honest, I think one problem is that we haven't done it a lot because we tend to lose these infants in terms of care. Like, I'm not sure what happens, honestly, after they're getting born. So I would love to start collecting that information. In my experience, I haven't heard of any moms that come back and say that insurance didn't cover that monitoring for their infant. But I would be really interested if anybody else has had that issue.
Wendy, can you explain your process for dosing ETI in children less than 2 years? Specifically, we have another question about the baby who was only a few months old. And are you looking for any other outcomes or side effects besides liver enzymes and cataracts for this off-label use?
So I wish Dr. St. Petery was still here. She has this document, and I'm not sure if any of you have seen it yet, but it is an extrapolated document, and it may be Dr. Fortner's, I'm not really sure, but it talks about patient weight and dosing. And so what it ended up being was like, it started out at 1/5 of a packet in the morning and at night, and so in the pharmacy, we opened up a packet and we counted the total number of granules. And we made sure that that was consistent. We did it through a couple of packets as we were using it, and we have mom count out the number of granules. So she will actually open the packet, and it'll be like 25 granules in the morning and 7 granules at night. And as it goes up, we'll change the number of granules that we're able to use based on that weight. It's been effective. Is it the right dose? I don't know if we know yet. I think there are several centers using this dosing algorithm with it, and I would be happy to share it with you. I will find out where it came from before I share it, but it is Dr. St. Petery who dosed it with me, and we really, like when he was in the hospital, we had the pharmacy actually like within, as one of the stat meds that you have to prepare right on time so that there wouldn't be a delay, since we know it's only good for so long out of the package. So it was like an urgent med where they would count them and immediately deliver to mom. And then what was the second part? Do you remember?
Yeah, it was just dosing less than.
Yeah, and then we dose based on weight. So I remember we started at like a 5 kilo dose, and at 7 kilos, he'll go up again. So like it is a weight-based progression up to full dose of the ETI. And side effects, we've mainly monitored LFTs and eye exams, and we've not been aware of any other side effects. I mean, we looked. We always counsel on like potential GI stuff, but I think it's so hard to tell in an infant to know if it's related to that or not.
For Sarah and Lena, do you have a standardized or stepwise approach for how you might decrease the dose?
Yeah, so it depends on where the patient is in terms of weight-based dosing. So if the patient had previously been on the blue and the green packets and we had recently increased to the orange and pink, we would potentially consider just going back down to the lower dose packets. If the patient is already on tablets, then we would start by taking the blue tablet off first and then take one orange tablet off next. That's pretty much our starting point, our stepwise approach.
And then for babies that are exposed in utero to ETI, have any of you had to recommend a drug holiday before you do an accurate sweat test in terms of diagnosing the infant with CF, not just based on their genetics?
So we have not. And so we have three recent the moms that we talked about, and the moms have all been hesitant to withdraw drug. And because all 3 babies or children have drug now, and we know their genotype, we have been able to get it approved. So I really think the only reason we would potentially pull it away at this time would be if insurance, that is something they need to see for approval. And then they may talk about pulling it away.
Do you have any?
No, I was just going to say that we actually did ask a few questions about this on our survey. And come talk to me tomorrow if you want to know those details, because I don't remember them right off the bat, but I know that a lot of people had responses about this question. So we did look at it, but I don't know off the top.
And another question, are you monitoring amylase and lipase in these patients?
I don't know the answer to that right off, but I can find out and add it back to the listserv. I know we are measuring fetal lactase for pancreatic sufficiency or insufficiency, and 2 of the babies are not on pancreatic enzymes, and I'm pretty sure the one that I talked about that had so much trouble is still on some enzyme replacement.
How does the clinic identify non-CF moms pregnant with CF babies to help facilitate initiating ETI? And then kind of related, what advice would you give to OB physicians when caring for pregnant patients about when you would want them to be referred for ETI?
So we currently don't have a way of identifying the moms. We got lucky in 2 of them, and in one, the mom kind of sought us out after she did some research, and her OB was not in support of doing anything or wasn't aware of it. So I think the best way that we can move forward is just make sure that community OBs and community genetic counselors that are not part of like a big medical center are more aware that there may be options out there. And when to start, like, I don't know the answer to that. Our genetic counselor is like, now, you know, because she's in the camp that the earlier the better. We may really prevent pancreatic insufficiency and potentially fertility. But I think that really has to be a discussion with comfort level of mom and dad. I think that our center potentially would be very willing to offer it to most moms with close monitoring of LFTs and then just following along. But we haven't quite had anyone start it earlier than the cases that we've reported.
So one question that I think many people might have is that we know that families who either the person themselves has CF or their child has CF, we know that they're very connected to the CF community and they share a lot on social media. And so a lot of times we have people come into clinic and they say, hey, this baby is 9 months old at this center across the country and they got ETI, why won't you give it to me? So can you comment a little bit about kind of what your guys' thought process goes into and like how you determine what off-label use you're going to offer and how you might handle those situations that you have, these families coming in talking about experience at other centers?
Maybe y'all want to have it happen? So we have not had that happen, but I think we would have to look at the health of the child and potentially the possibility of getting it approved. We have one 7-month-old now that mom's breastfeeding and all is going well, but we know at some point mom is likely not going to want to breastfeed anymore. And so it's on my appeal list, and we've just kind of set a goal of like within the next month or so, I'm going to work on it. The child is doing great. I don't know if we'll be able to get it approved. I think that we got lucky with our infant in the NICU because he was not thriving at all. Like, it was miraculous. Like, I have no other word than miraculous to describe when he started on therapy of his own versus the breast milk. Like, he turned the corner almost immediately. So I think we were able to argue that with the insurance company, like, this is what we think is going to happen. And I think that has sustained the approval because he is doing so well. But we were able to say, he's already been in the NICU for however many weeks it was at that time, 10 and a half weeks. And there's no outlook of him getting out of the NICU right now. And so, within 2.5 weeks, 3 weeks, he was home. And so I feel like our center has become very aggressive because we saw that happen. So it's our positive, we realize it's skewed, but it's our positive reinforcement to see this happen.
Yeah, we thank you for sharing your experience. And I think that, we all have our own way of practicing, and we all work with different providers who you may work with 2, 3, 4 providers, and they would all do different things in the same circumstance with that same patient. So it's really, partnering with your colleagues and with the patients and the parents and what they're comfortable with, because it can have a dramatic improvement in quality of life.
This question is for Sarah and Lena. How do you assess side effects after you do a dose increase and not just the new start? How does that affect your screening frequency?
So we do the same cadence with a new start and a dose increase. So when a patient is increased due to a weight change, we follow up within 1 to 4 weeks after dose increase.
Have there been any male babies born with a diagnosis of CF to a mother on ETI? Has the vas deferens formed properly?
Not that I've read in the literature. I mean, the only data I was able to find was the ferret data that's out there. And that's what convinced our first mom to come to and beg us for early access. And she actually told us that if we didn't get Trikafta for her baby after it was born, she could get it on the black market, and had bought a scale and was crushing it and going to weigh it out. So, I mean, I think we have to be aware that some families are so passionate about this, we can either do it with them and monitor it, or they're going to do it anyway. And she was one of those moms that was going to do it anyway. And so we would have been on board with her, but she made it very well known that if we were not, she was going to just go do it. I did not know Trikafta was on the black market, but if you read the Atlantic paper that was sent to me, it's from March. Carissa sent it to me, talked about moms in the United States and moms in Europe that are buying Trikafta for this reason, off-label.
Or if you come to our center, they just find a kind individual with extra Trikafta and get it shipped when the appeal takes too long. So people are doing things, and so I agree with you. It's important to partner.
Well, I think that is most of the questions that we had there in the app. Thank you all so much for attending this session. Thank you to the program planning committee for offering us this platform to talk about these issues. I think it was really informative, and thank you to all our speakers.
Thank you.